So yesterday I talked about pharmacokinetics absorption. The first part was absorption. So today I will be beginning with the distribution. As the name suggests, that distribution means that when we take a drug or administer a drug, then it gets distributed in our body, and this distribution is a reversible process, and by this the drug reaches to each and every part of the body. So at the end of today's lecture, you are going to understand what distribution of drug is, what are the different compartments of drug of the body, how the body is divided, and then the binding of drug to the different proteins and their effect in distribution. Then what is the concept of free drug, then apparent volume of distribution, and then what the redistribution of a drug is. So distribution is a reversible transfer of drug from one location, that is usually from the site of its absorption, then its movement to another site or another part within the body. That is the distribution of a drug. So it includes the passage of the drug from circulation to the tissue as well as to the site of action. And what are the different factors which are going to govern this distribution are the lipid solubility. The more the lipid soluble a drug is, the more easily it passes through the biological membrane. So the more distributed the drug will be. So lipid soluble drugs are more widely distributed. Second, the ionization at physiological pH. The less the drug is ionized, the more the drug will be distributed. Less ionized or unionized drug freely passes through the biological membrane, so it will be distributed more. Then third factor which influence is the extent of binding to the plasma proteins or the tissue protein. So the drug which is bound to plasma protein is largely confined to the intravascular volume. So it is not going to get distributed in the body. So if a drug is having high binding to the plasma protein, it will be less distributed. And the drug, if it is bind to the tissue proteins also, then it will be less distributed. Then one more important factor is the differences is in the regional blood flow. The more is the regional blood flow to a particular organ, the drug will be more distributed to that site or will reach quickly to that site. And the less vascular or the if the regional blood flow is low, the drug will be less distributed to those sites. Then disease conditions like heart failure, uremia, or cirrhosis, what these diseases are going to do, they are going to affect this plasma protein level. So when the plasma protein level will be low, so the binding of the drug to these plasma protein will be less, so the drug will be more distributed. So the movement of drug occurs until a equilibrium is set between the unbound drug in plasma and the tissue fluids. So it is basically the free drug which is not bound. It can easily cross the biological membrane and get distributed. And there is always an equilibrium between the bound drug and the unbound drug. And this equilibrium is can be set in both the ways. That means if the bound drug decreases, then the free drug moves towards the bound. More bounding of the other remaining drug will occur, and an equilibrium state will be set. So that I will be explaining you further in the when I am going to talk about the plasma protein binding also. So if we see the fluid distribution of our body, then approximately it is 40 to 45 liters. That is the total body is made up of water. So it is around say 42 liters, and out of which the 2/3 of the liquid is present intracellularly, that is around 28 liters, and extracellularly it is around 14 liters, that is the 1/3. And out of this 1/3 of the extracellular water, around 1/3 is intravascular, that is around 5 liters we have the blood. Then the interstitial fluid is around 9 liters, that is the 2/3 of the extracellular fluid. And in the intravascular also, plasma is around 2.5 to 3 liters, and RBC accounts for 2 liters. And if we see the human body, so in the fetus it is 100% is water. Then as with the growing age, the water content of the body is also decreasing. From the baby at birth has 80% water, 70% at adulthood, and elderly persons they have 50% of the body as water. Then very important concept is in the distribution of drug is to understand the compartments, in which compartment the body the fluid is going to be the drug is going to be distributed. So if we see the blood, the blood vessels, that is the intravascular fluid, and the things become easier, but our whole body is not a single compartment, that the drug is homogeneously distributed throughout our body. The uh, we have we have the intravascular fluid, we have the interstitial fluid, then we have the further the intravascular intracellular fluid also. Then on the cells also the drugs can be distributed. So for ease of understanding, we say we take that one is the intravascular fluid, and other compartment it incorporates the two in the two compartment model. One is the intravascular, other is the extravascular volume. That means the intravascular volume it is around 5 liters, and the rest 35 liters around, that is which includes both our intracellular as the interstitial fluid. So the drug gets distributed from the intravascular. Then as we take a drug, that after absorption the drug reaches into the blood vessels to the systemic circulation. Then from the intravascular fluid the drug gets distributed into the interstitial fluid, and then to the intracellular part. So it is the movement of the drug which occurs, and this is the compartment model. But basically our body is composed of multiple compartments. For ease of understanding, we take it as a two compartment model. So what is then very important concept is the plasma protein binding, and you often get short note to write on plasma protein binding. So in the blood we have, in our intravascular fluid, we have two important plasma protein. One is the albumin, other is the alpha 1 acid glycoprotein. The acidic drugs they get bind to the albumin, and then they are distributed throughout the body, while the basic drug they bind to the alpha 1 acid glycoprotein. So these are the two proteins to which the acidic and the basic drugs bind, and they remain in the intravascular volume fluid. So it is actually the free drug only which will be distributed or which moves out of the intravascular fluid. The bound drugs, those drugs which are bound to these proteins, they remain inside the intravascular fluid. That means they are not free for producing any effect or action. Only the free drug, it is the free drug which will move out of the vessels, will go to certain sites of the body or to the binding site of the body. There they can be stored. There they can bind to their receptors, or some mechanism can occur, and they produce the different effect, like analgesic effect, any effect they are going to produce. So it will always be the free drug which will move out of the blood vessel. All the bound drugs they will remain inside the blood vessel. So the free drug will move and to the site of its action and produce the effect. So that is the very important concept of free drug, that it is always the free drug which is going to produce the effect. And one more important factor, what happens if a drug is bound to these proteins for a longer duration? What will happen that these drugs will remain in circulation for a longer duration, because these will not be excreted out also, because albumin or in normal circumstances these proteins are not excreted from the body. So those drugs which remain bound to these proteins, the drugs will remain constantly in our in the intravascular fluid. So these drugs become longer acting drugs. So these will have a longer duration of action, and slowly. And there is an equilibrium between the free and the bound drug. As soon as the free drug decreases, then the drug from these bound sites also dissociates and then move to the site of action. So slowly they will be getting released. Or if the bound drug is decreasing, then this free drug will move back into the intravascular compartment to form the bound drug. So there is an equilibrium between these. Because of this, the drug effect lasts for a longer duration. An important example is warfarin is a longer acting drug. So uh, because of its high plasma protein binding. Then one very important effect of this plasma protein binding is one more important effect is the displacement reaction. Suppose a drug is having very high plasma protein binding like warfarin, and if we take simultaneously another drug like salicylate or phenytoin, what these drugs do, they replace warfarin from the plasma protein binding. So what will happen? The thing which will happen is that when a drug is displaced from its bound form, so what will happen? More of the free drug will be available. So more of the warfarin will be released. So warfarin is an anticoagulant. It is an oral anticoagulant. So more of anticoagulation will be there. So there can be hemorrhage, there can be bleeding, or severe side effects of warfarin can occur. Okay, so this displacement reaction is very important, and the drugs which are having high plasma protein binding are contraindicated to be taken with those drugs which are going to release them from the plasma protein binding, or they are going to make it free. So these drugs will be contraindicated over here along with such type of drug. And one more important factor is that I have talked about CHF or uremia. So if any condition is there which is going to decrease these plasma protein levels, so what will happen with these type of drugs like as warfarin, which is having high plasma protein binding, so slowly the drug is being released, so a normal therapeutic effect comes. If a patient is having lower level of these uh, plasma protein, so the bound form will be less. So when the bound form will be less, more of the free drug will be going uh, for action. So the availability of the free drug will increase. So in such conditions, such disease conditions such as CHF or uremia, we have to decrease the dose of these drugs also. So that is a very important clinical implication. These are the important clinical implications of the plasma protein binding. So once a drug reaches to the tissues, then it can cross the blood-brain barrier if it is lipophilic and get distributed to the brain, or can get deposited in the adipose tissues, or in the muscle fibers, or to the bones, or cross the placenta and reach the fetus. So this is normally what the distribution can happen. Then these are the tissue storage site for different drugs. These drugs, like digoxin, has affinity for the muscle protein, so gets distributed into the heart or the skeletal muscles. Like chloroquine, tetracycline, these have propensity to get stored in liver. In the kidney, it is digoxin. Then thyroid, it is iodine. Brain, it is chlorpromazine, isoniazid, and chloroquine has affinity for the nucleoprotein, so distributed to retina. So the toxicity of chloroquine is also there in the decrease in the vision. And then ephedrine or atropine has affinity to the melanin of the iris. And for the bones and the teeth, discoloration occurs with the use of tetracycline. Heavy metals have affinity to the mucopolysaccharides of these connective tissues. And then DDT, thiopental ether, they have the high tissue storage for the adipose tissues. So these are the different affinities, and so these drugs are stored over in these types of tissues. So if we again, I have talked about the blood-brain barrier. So it is the astrocytes which lay the layer around the endothelium. The endothelium is also having the tight junctions. So the blood-brain barrier it comprises of the capillary endothelial cells which have tight junctions and lacking the large intracellular pores, and an investment of glial tissues over the capillaries. So this makes these capillaries leak proof. So, and similar barrier is located in the choroid plexus. Thereby these form these are lipoidal, and they limit the entry of the non-lipid soluble drugs such as amikacin, gentamicin, neostigmine. So the only the lipid soluble or the unionized drug, they penetrate through these barrier and reach the CNS for the action. And a part of this, they have the P glycoprotein, which is present as an efflux pump, and they help in the extruding. They help in the moving out of of the drug out of the brain. These barriers, or these blood-brain barrier, get disrupted in inflammation, and then can penicillin can cross it. So then in cases of meningitis where there is inflammation, then we can give penicillin. And in normal conditions, this penicillin is not going to cross that blood-brain barrier. And one more important implication is that dopamine does not enter brain. It doesn't crosses the blood-brain barrier, but its precursor levodopa does. So what happens? We give levodopa for the treatment of Parkinsonism, where there is degeneration of the dopaminergic neuron. So what this levodopa? It is the precursor of dopamine. So when we take levodopa, it can easily cross blood-brain barrier, reach the brain. There are converting enzymes, decarboxylase. So they will convert the levodopa into dopamine. So this dopamine becomes available in the brain for the treatment of Parkinsonism. So we use this drug, not the dopamine. Similar to the blood-brain barrier is the placental barrier, which is laid by the trophoblast. And if we see the fetal blood, it is slightly acidic. And so, as I have told, that the effect of the pH is there on the ionization of the drug. So, in the acidic media, what will happen? The basic drugs will be ionized, more ionized. So the basic drugs will, when once they will enter into the fetal circulation, they will get trapped over there. So this is the ion trapping. So the level of the basic drugs will be very high in the fetus. So these can produce toxicity such as lignocaine or the beta blockers. So we have to be very cautious while giving such drugs to the pregnant females, especially during the first trimester. As we all know, that organogenesis of the fetus occurs in the first trimester, and in the third trimester also we have to be very cautious, because the functionality of the fetus during labor can get hampered with these drugs during the labor. So the labor can be delayed also. So we have to be very cautious while using these drugs during these trimesters. And only it is the lipid soluble drugs which can penetrate through this, and there is a limitation of the hydrophilic drug. They cannot easily cross this. Then there are placental glycoproteins, which serves as the limiting factors. And point to remember over here is that these barriers are incomplete barriers, and there a part of that, there are some influx transporters also, which can easily transport certain drugs such as thalidomide. You must have heard the name of the thalidomide, which cause the seal like limbs in the newborns. This thalidomide was taken by the pregnant females, and for morning sickness, and this led to the disaster where the limbs of the newborns, they were fin-like, appearing as seal. So coming to the one more interesting topic, or the part of this pharmacokinetic distribution, is apparent volume of distribution. So if we consider the whole of the body as a single compartment, then and the drug get distributed evenly, okay, or if in the different compartment the drug concentration is same, then this volume is actually the whole volume of the body that is going to accommodate all the drugs. That is but why this apparent is added, that I am going to explain. Because it doesn't happen that the drug concentration in each and every compartment is the same. So if we calculate the volume of distribution, it is equal to the total amount of the drug in the body divided by the concentration in the plasma. But it is not a real entity. Why? Because the whole of the body is not a single compartment. And what happens? This I will explain you by, if we are giving digoxin to a patient of a cardiac failure. What happens? We give a dose of 500 microgram, and we see the plasma concentration is 1 microgram per liter. So if we calculate the volume of distribution of digoxin, we get 500 upon 1. That is 500 liters in a 70 kg man. So how right now I have told that the total water content of the body is somewhere around 40 to 45 liters. Then from where we get this 500 liters of distribution? from where why this 500 liters happens to come in our body. So that I am going to explain you. So we call this as an apparent volume of distribution. So similarly, so if in a 70 kg male, if we see the volume of distribution, then for many, if a drug is having a volume of distribution of 5 liters, suppose, that means the drug is going to remain largely confined in the intravascular fluid only, because it is 5.5 liters. So if warfarin it is 7 liters, so it is more or less it is in the intravascular fluid only. If a drug such as aspirin is having volume of distribution of 12 liters, that means the drug is being distributed to the intestine, extra cellular fluid also. Okay, and if we see a drug like amoxicillin has a volume of distribution of 20 liters, that means it is distributed both in the extracellular fluid as well as the intravascular fluid. And if we see a drug like phenytoin, it is having a volume of distribution of 50 liters. That means it is distributed in all the three parts, all the intracellular, extracellular, as well as the intravascular fluid. But when we see one more drug, chloroquine, it is having 15,000 liter of volume of distribution. What happens? It gets distributed to the various tissues, and it gets bound to the tissues and get absorbed over there. So this volume of this large volume of distribution comes from. I am going to explain in the next slide then how this 15,000. So if we take a normal beaker and water in it, and we add a drug in a dose of 10 milligram, and we see if we get a plasma concentration of 20 milligram per liter. So if we calculate the volume, it is 10 upon 20, that is 0.5 liter or 500 ml. So that is the concentration, that is the volume of this beaker. So, and when we are going to add some charcoal, you must know that charcoal acts as an adsorbent. So, what happens? It absorbs the drugs. So, when we give a drug in a dose of 10 milligram, and we get a concentration of 2 milligram per liter, so the apparent volume becomes 5,000 ml. Okay, here it is 500 ml, it is 5,000 or 5 liters. So but the level, if we compare, the level of the water is same in both these beakers, but due to the presence of this charcoal which absorbs the drug, the plasma concentration is less. Similarly, it happens with the chloroquine also. What happens? The plasma concentration will be remaining low, but the amount of the drug which is being distributed is very high because of this adsorption. The drug is being absorbed by the tissues also. So the body is not having only just these two compartments, but the tissues and all the things, they are having different absorbing capacity. So more, and so this volume of distribution is known as the apparent volume of distribution. Next important one of the important concept is of redistribution. What happens that when we take a drug, it reaches to the systemic circulation, then the drug reaches to the heart, and what the heart does, that it pumps out the blood. And firstly, the highly perfused organs such as the brain, heart, or the kidney, they will receive the blood. So highly perfused organs, they are the plasma concentration of these drugs are going to rise much more faster as compared to the less perfused organs. Then after reaching this, so the drug will reach over here quickly, and the drug will move out back to the vascular compartment also quickly from this side. And then from the circulation, the drug gets redistributed to the less perfused organ. This is the redistribution of a drug. So one very classical termination of the effect of a drug occurs due to this redistribution concept, and it is a very classical MCQs are based. Thiopental sodium is an IV anesthetic drug, that is, it is being used for producing anesthesia. And what happens? It has to inhibit the brain. So as soon as the IV injection of thiopental sodium is given, The blood, due to the high perfusion of blood in the brain, this drug reaches the peak concentration very quickly in the brain. It inhibits the brain, and anesthesia is developed very quickly. And very quickly, the drug again gets redistributed. So the plasma concentration in the brain also comes down very fast. And this redistribution, as soon as the plasma concentration comes fast, the effect also weans off, or the effect goes. So the duration of action of this thiapental sodium is 2 to 5 minutes. That means the duration of action is low because of this redistribution to the less perfused organ from the high perfused organs. Further, I will be explaining. Suppose we see the percentage dose, and this is the time curve. So in the blood, as soon as we give a IV fluid, IV drug, so maximum dose is achieved, and within minutes it will fall, and after some minutes, within a minute it will fall very fast, and then within few hours it will decrease. And if we see the plasma concentration of the highly perfused organs such as brain, so what happens, slowly, very within a minute, there will be a peak plasma concentration of such drug. The plasma concentration in the brain, if we see, it will rise very quickly, and then within few minutes, 1 to 30 minutes, the plasma concentration will fall down, and within few hours it will be totally gone. But when we see of a muscle, it will take more than few minutes to reach the peak, the maximum plasma concentration, and within hours it will come down. And if we see the very less perfused organs such as fat, so what happens? It takes hours to reach the maximum plasma concentration, and then it comes down. So with this, we can understand the highly perfused organs, the plasma concentration of the drug is reaching very quickly, and the low perfused organs, they are what is happening with them, that the plasma concentration is reaching very slowly. So the next is, what are the different factors which are going to affect this distribution of drug. One, I have told that lipid solubility, more lipid soluble drugs are more distributed. Ionization, less ionized drugs are more distributed. Degree of plasma protein binding, less plasma protein bound drugs are more distributed, less distributed. And then affinity for different tissues, the presence of tissue specific transporters are there, more will be the distribution. Then the differences in the regional blood flow, more perfused organ, more distribution of drug is there. Then diseases such as CHF, uremia, cirrhosis, they are going to vary the plasma protein binding, and thereby the distribution of the drug. So if you have any question, you can ask me. That was all for today.